Yeah.
Hello, everyone. I am your MC for the day, as of 20 seconds ago. I'm Drew Tice. I'm a senior here in the Anthropology department, studying cultural and linguistic anthropology. So our first presentation today is Horan.
Horan.
Yep.
Mm-hmm, no problem.
Presenting Mosquitoes, Maternal Stress, and Maria.
Yeah.
Sorry.
It's okay.
Conducting biocultural, medical, anthropological fieldwork in Puerto Rico. Great. So let's give it up for Horan.
Give it up. All right. Thanks. This is, just set my tea over here. Just skip this over a little bit. If it gets too loud, would it be possible to close the doors? Is that an option?
I don't know, but I'll check.
Okay, thanks. Good afternoon, everybody. My name is Holly Horan. As was stated, I'm in the very, very last leg of my doctoral degree here in applied anthropology at Oregon State University. I returned from the field last year, and I've been working on writing my dissertation throughout this year. And so today, I'm not going to focus so much on findings and theoretical concepts, though we will touch on that, but I want to talk about the experience of doing fieldwork, what that looks like, the struggles involved, the logistics involved in doing fieldwork and doing anthropological research, because something that I have found as a graduate student is that a lot of people get involved in graduate school and then they're like, oh, this is different than what I thought. This process is different. So I wanted to share my experience and hope that that can kind of give people some insight on what the work looks like. So yeah, and then there'll be some fun things smattered in and out of there, but anyways, I hope you can hear me okay. I think does this mean that it's on? Does this mean that it's on? Okay. So why Puerto Rico? Well, my mom is Puerto Rican, my grandmother's Puerto Rican, my great-grandmother's Puerto Rican. This is a photo we took just recently this fall with my daughter, and this is my great-great-grandma in that picture. So it's a meaningful place for me. I really, really care about Puerto Rico and the well-being of Puerto Ricans, as well as the well-being specifically of maternal and infant health populations in this country, because Puerto Rico is actually part of the United States. It's an unincorporated colonized nation and has been since the late 19th century. So this is the first reason why Puerto Rico and why it's meaningful to me. And I encourage you all, when you think about your own research, to try to find some meaning and and to think about where you're doing your research and how it's meaningful to you, because I think that can really drive you when things get hard. So I'll definitely say that as well. A couple other reasons that I want to do my research in Puerto Rico is that there's something called the Puerto Rican health disadvantage, and it's primarily applied to U.S. residing Puerto Rican populations. But if you take the overall subgroup of Hispanic and Latinx populations and you break them down epidemiologically or by numbers, and you look at the some specific chronic and degenerative diseases, as well as a number of maternal infant health outcomes, you see that Puerto Ricans have one of the highest rates of poor maternal and infant health outcomes, specifically preterm birth, specifically low birth weight in the US, both residing in the state's lower 48 population and the population that lives on the island. So this often gets overlooked because those groups get lumped together, but this is something that has been called to attention in the literature and needs a lot more investigation, particularly in comparing island-based and lower 48 residing populations. A couple of other things that are really interesting to me is that Puerto Rico has had a pretty high preterm birth rate for a long time. And it's actually come down a significant amount in the last 5 years, but it's kind of in this stubbornly higher state of about 11.5%, and it's always consistently a little bit higher than populations that we see in the US that are non-Hispanic, but it's always consistently about 2% lower than non-Hispanic Black populations. And so one of the leading theories in terms of prematurity and maternal stress talks about this concept of allostasis. So to be really simple about what allostasis means, it's our body's overall system in response to stress. And that if that system is constantly being used, constantly being stressed, you're never finding a place or a time to release that stress or to have a response where you're in a non-stressor state, it can basically shoot or wear your system. And so we're trying to understand how this relationship between maternal stress and allostasis, or what they call also allostatic load, impacts maternal health. And that's something that is currently under investigation. That is what my research contributed to, in addition to a number of other things. But it's figuring out, how does stress impact maternal physiology or women's bodies, and how does it affect birth? And there's only one study that's ever been done in Puerto Rico looking at the relationship between the high preterm birth rate and common epidemiological variables that we see in the States, like maternal education parity, so the number of babies a mom has had in her past or pregnancies she's had, access to health insurance, prenatal care, etc. And there was no statistically significant correlation between these variables and the preterm birth rate in Puerto Rico, according to this one study done by Northeastern University. So that's something else that kind of makes us maternal and infant health researchers very, very curious. And then the last thing is that we know from general literature on maternal stress and prematurity, or what we call gestational age at delivery, which is how old your baby is when they're born. And stress is that there's also a lot of health system factors involved, and we wanted to know how those health system factors, particularly in a colonized nation, were unique and potentially contributing to these outcomes. So here I've just put up some descriptive statistics for you in terms of maternal and infant health outcomes that come up a lot in my research. So preterm birth rate, and so preterm birth, let me be clear, I apologize I didn't clarify this earlier, is a birth before 37 weeks of pregnancy. And low risk cesarean is when the baby is head down and in an optimal position for vaginal birth and is a first-time mother, but for some reason there's something that caused that mom to have a cesarean birth, and they call that the low risk C-section rate, is 40% in Puerto Rico and about 26% in the US, and then in Puerto Rico they have a total cesarean section rate of 46.2%, which is almost 1 in 2 mothers, and as we can see it's a little bit lower in the lower 48, excuse me. And one of the reasons contributing to that cesarean section rate is that there are very limited options for what's called VBAC, which is vaginal birth after cesarean. Okay, so let's walk through the process of arriving to this research, to doing this work. And so I'll start back at my pilot study, which was conducted in the summer of 2014. It was my second year here as a doctoral student. And what I wanted to do in this study was just to talk to maternal and infant healthcare providers about what were the greatest maternal and infant health issues in Puerto Rico from their perspective, and what were the supports and barriers to improving or exacerbating these outcomes. And one of the important pieces of this is this process is called studying up. Laura Nader, anthropologist, 1970s publication, talks about how we need to understand what's going on at the institutional level, because we often are studying people on the ground and we're often studying people from disenfranchised positions, but we also need to understand what's going on with individuals who represent the institutions to have a really full understanding of inequity. So the pilot study included 20 semi-structured interviews with maternal and infant health professionals, and this included perinatologists, obstetricians, labor and delivery midwives, nurses, doulas, midwives, or parteras. And we asked them the same types of questions about what I just discussed. And the 3 biggest topics there were the health system infrastructure, a high rate of preterm birth, and a high rate of cesarean section. And they are all interrelated in ways that I wish I had a whole another hour to talk about. But one of the things that we decided to do while also doing this research was say, well, what would you prioritize? So I told them about what I was interested in. I'm interested in stress. I'm interested in understanding how stress impacts maternal and infant health outcomes. And we talked with them about pulling together a project that focused on prematurity and stress, because all of us, providers and researchers, were aware that there was a potential connection there. So that's why we call this work community-led research, because they informed a lot of how I shaped my project. But I wouldn't call it community-based participatory research, because no one was calling me as a new PhD student being like, you got to come here and study this. I know your mom's Puerto Rican. So it gets a little bit methodologically problematic to co-opt the term CVPR when it's not truly CVPR. So we came back, we transcribed that data, we identified those 3 themes that I talked about, and we came up with a research question that shaped the doctoral research that I conducted. And so I'll read you our primary research aim and then we'll break it down. So to investigate the biocultural production, so what's happening physiologically, what's happening socially or culturally, of maternal stress in the United States territory colony, and to determine whether, and if so, to what extent maternal stress contributes to the high rate of preterm birth in Puerto Rico. So there are studies looking at the relationship between stress and prematurity, but this study is one of the first to have women's voices at the fore of of how stress is impacting lives, outside of a scale, outside of a survey that checks a question, maybe with a general description of their stress experience. So I'm really, really excited about this work, and maybe some of you will be too. Okay, so moving on from the pilot study to the first phase of my doctoral research, where we conducted semi-structured interviews. We did data analysis while we were in the field, and we used data from these semi-structured interviews to shape the validated stress scales that we were using in the second phase, and I'll talk more about that in a moment. There's a picture in here somewhere, I know it. Okay, so, and that's my daughter. She was a great research assistant. So how did the process look? Well, I spent the greater part of 2015 and 2016 writing my IRB, because turns out when you do a complicated project in 2 languages, that takes a lot longer than you ever would think. So I got IRB approval in 2016. I applied for funding also during that year, and as you saw in the first slide, I had funding from SILF, NSF, and OSU to do this work. And then once I was able to get my funding, I finally was able to go into the field in July of 2016, and I was very, very excited. So I kind of established my life there, and then I started recruitment for this first phase on August 1st, and I had one research assistant who came from Oregon State to help me do this work. And I've had a number of students working with me on this project, so it was really, really exciting. And so we recruited at 2 different sites. We recruited at a community-based maternal infant health center that we had connected with during my pilot study, and we also recruited with a group at a private hospital not far from there, and it was a postpartum support group, and both of these individuals were participants as providers in my pilot study. So now we're starting to see the connections between why you do pilot work and how important that is for successful subsequent research. And we provided verbal consent to all the moms. We would go and sit at these clinic days. We would go and sit in these postpartum groups. They would introduce us. Everybody was a little like, that's kind of weird at first. But I had my baby, and I think that really was helpful for a lot of moms to realize that I'm more than just a researcher. I'm more than just someone wanting their experience. I can feel some of their experience. And so eventually, over the course of about 3 or 4 weeks, these moms started being like, yeah, I want to talk to you. I want to share my experience with you. And so we would say, okay, we can do it now. We can do it over the phone. We can do it at a place of your choosing. And so they would decide when and where it happened. And then we would ask them to verbally consent to the study before we collected any data. Something important for all of us to keep in mind. And we also administered a demographic or eligibility survey. So this survey had questions about their demographic background. The first question was whether or not you were pregnant. So that's an important thing to do when you're studying pregnancy and stress, is to make sure that they're pregnant, or recently postpartum in our case too. And also questions about their obstetric and health history, as well as some other various questions about their experiences of stress and how frequently they experience stress. So that's important to have some measurable items up front. And then after they completed the survey, we did the semi-structured interviews. And so we did a total of 25. And so I'll share 3 things that are really interesting about this project. So as you know, we started the project in August 1st of 2016, right before the island declared Zika as a public health emergency on the island. And we know that Zika, pregnancy, stress, those 3 things are going to clearly be related. So something interesting that I found in this work, though, is that everybody was calling me, all my researchers, the funders, everybody was like, how is Zika affecting these moms in Puerto Rico? And a lot of the moms in Puerto Rico say, they're like, it is stressful, and I'm doing what I can, but there's only so much you can do. And so instead of being this like additional stressor, instead of being this thing where everybody's lives were focused on not getting bit by a mosquito, it was more of a compounding stressor to their daily life experiences. And I talk a lot about that in the 3rd chapter of my dissertation. But something important to point out, because everybody's like, is everybody getting abortions? Is everyone freaking out? And I'm like, no. There's concern, but it looks a lot different than what we expected. And a lot of the concerns that mothers did have was related to a lack of information available to them on what to do about Zika. So that, to me, is a sign of a structural issue. The second thing that was really interesting to find in this study was that a lot of the mothers talked to me about a number of things that are happening in maternity care that we at least don't hear about, if not don't see in this country, or in the US, in this continental US. And so one of the things is that privately insured mothers could go to their provider, and their providers who get paid 2/3 less than what providers who serve Medicaid and private paid physicians get in the continental US. They would say, oh, well, we have this additional fee that you need to pay. You need to pay this additional fee, and they would have a breakdown of what the fee was. And it was for like the TVs in the waiting room, the gel warmer, so on and so forth. And like, you have to pay this, this is part of our services. And even though these people would contact their health insurance companies and they'd say, no, you don't have to pay that, that's not, your services are covered, you don't have to pay that. Then these moms in the third trimester would go and finally say, I'm not paying this bill. The providers would ask them to go elsewhere in their third trimester. So that is something that we don't hear about here in the States anyways, but may very well be something that's happening and we're unaware of it, but that is something that I have not heard. And so that is a huge stressor for moms. And the third thing that I'll share so far that I have found is that a lot of the mothers blame each other for their own stress. They say, it doesn't matter what's causing you stress, it's your responsibility to control it. And I go on and on and on in my dissertation about how there are so many structural barriers to controlling your stress, but it was a very, very big priority for them to, whether or not they were managing their stress, to look like they were and to make sure that their family felt like they were, because they knew that their family would be concerned for their stress if they weren't managing their stress. So I'm getting stressed just talking about that, but yeah, so some interesting findings there. So after we collected this data, we transcribed and translated everything, myself and 2 research assistants, and then we did some preliminary coding to find some themes that could add additional questions to 2 validated stress scales that we used in the second phase of the clinical phase. And these scales are the Cohen Perceived Stress Scale and the Revised Prenatal Distress Questionnaire. They're both 12 questions or less. They both have Likert scale responses. And we wanted to make sure that anything unique to stress experiences in the Puerto Rican context were included on these scales. So there are a couple questions about Zika and a couple questions about being able to cover your life expenses that were included in both of these surveys that we added. And then we commenced the second phase. And this is one of my research assistants, Fabiola. She's measuring a hair sample at one of the clinical offices there. And she was going to do all these she was going to do any of the follow-up visits that I couldn't do before I had to leave and come back from Puerto Rico, but we'll talk about why that didn't happen in a little bit. So we started recruitment in mid-December. We did convenient sampling. Again, very similar process. Verbal consent with the mothers when they came. We all came. The clinics had 2 days a week where they saw first-time moms. So we would just come and like hang out at the clinic with our little flyers, and people would be like, yeah, I want to be in your study, or I want to hear more, and we'd go back into a room with them. And then when mothers agreed to be in the study, they would complete that demographic survey, the exact same one that we administered in the first phase. And then they would do these 2 scales, the Cohen Perceived Stress Scale and the Revised Prenatal Distress Questionnaire, and they did that at each time point we met with them in pregnancy, so we met once each trimester. And then they also offered a hair cortisol sample, or we asked for them to give us a hair cortisol sample, which is a tiny little section in the back of your hair. And we cut that, and we cut from the same spot every time at each prenatal visit. And that was giving us our biological measure. That's what makes this biocultural. It was hair cortisol, and cortisol is one of the hormones in our body that is indicative of our stress response. And then finally at the end, we asked them to do a postpartum exit interview where they would review their scale responses and reflect on their experiences of stress in general. And so everything was going great. Recruitment was awesome. We had like just shy of 100 moms. I was planning to leave in December of 2017. I was super excited. I was working with some of the women I really loved there. And then in February of 2017, we had 2 hurricanes come to the island. The first one was Hurricane Irma, and she didn't do much. There was a little bit of damage, but we all recovered a couple days later. We're like, oh, that wasn't so bad. Yes, we're almost done with hurricane season. And then 5 days later, we got warning that Maria was coming, and it was a much bigger storm, and it was projected to hit Puerto Rico. So I wouldn't say that this is the sanest thing I've ever done, but I did meet with somebody the day before the storm, like way up in the mountains, like as things were starting to get crazy. And so I have some pretty interesting experiences from that because I was just so desperate to see as many moms as I could before the study ended. But a lot of that time between those hurricanes was spent preparing for the hurricane. And the hurricane came and it devastated the island. There was no light, no water. We couldn't leave for 3 days. So we couldn't contact anybody for 5 days. My family was effectively convinced we were all dead. But we came back, OSU evacuated my family and I a week later. They didn't want me to stay, and I feel like that was a good choice. And then I was able to go back with the support of my funders in January of 2018 and get projects started. So I relocated all my moms, as many moms as I could. We called them, we asked them how they were doing, and then we asked them if they wanted to complete the study. And at this point, they could provide what was called patient-reported outcomes. So like, when was your baby born? Are you breastfeeding? How were they born? How much did they weigh? Things like that. And then we also did a postpartum exit survey. The majority of them were done in person because I went back to the island in February with my daughter, but some of them were done over the phone as well. So some preliminary findings from this part of the study. So this is a picture of what hair cortisol looks like once you break it down in the lab. And I was able to do all my own hair cortisol analysis at the human biology lab at U of O with an anthropologist there. 3 preliminary findings from here is that the first thing is that the cortisol analysis that we're finding is that moms with maternal morbidities and moms with poor maternal infant health outcomes tend to have a lot lower levels of cortisol than expected, which kind of feeds into that idea of allostasis as I was talking about earlier. So what happens when your allostatic load is shot? Something else that was really interesting that we're finding in the patient-reported outcomes is that 50% of women, only 50% less women breastfed after Hurricane Maria, so after there was less access to water for formula and things like that. And the second thing that we found that is really, really interesting is that Hurricane Maria has contributed to a much greater level of self-reported depression in the postpartum period, which is not unusual from what we see in disaster and postpartum literature to begin with. So definitely need to follow up on that. So briefly, this was our data analysis plan. I told you how we analyzed the data in the field for phase 1. When we came back, I did all my hair cortisol concentration analysis at U of O. We've transcribed and translated almost all the interviews, and we collected and logged patient-reported outcomes last summer. So the final thing I want to say is that a project of this size is not done alone. I feel like I'm up here talking about this work and sharing it, but there are so many people who have been involved in working with me and my advisor, Dr. Cheney. So this is the list of people that it takes, and you want it to be that way. You want it to be collaborative. So I just wanted to make that clear that I didn't do this work all by myself, and that a number of OSU students on here, including Allie, has helped me with transcription and translation. Then that's all I have for you. Thank you.